La siguiente sección la va a coordinar el doctor Segundo Nicolás Seclén. El doctor es actualmente presidente de la Asociación Latinoamericana de Diabetes, que es la asociación de diabetes más importante a nivel de Latinoamérica. Y él es médico especialista en endocrinología, formado en la Universidad Peruana Cayetano Heredia, donde obtuvo su maestría y doctorado en medicina. Se especializó además en epidemiología y salud pública, realizando estudios en ciencia política y geriatría en España y en Perú. Durante 40 años ha ejercido como docente e investigador, liderando investigación epidemiológica sobre enfermedades crónicas como diabetes, hipertensión, obesidad y síndrome metabólico. Fue parte del estudio internacional Diamond, demostrando la baja incidencia de diabetes tipo 1 en Perú, y también coordinó el estudio nacional Perudiab, evidenciando una alta prevalencia de diabetes y prediabetes. También ha colaborado en la promulgación de leyes, guías clínicas y dirige actualmente el programa Changing Diabetes in Children y estudios sobre diabetes gestacional. Es presidente de la Asociación de Diabéticos Juveniles de Perú. Y adelante, por favor.
Muchas gracias por sus aplausos y les pido concentración porque generalmente las sesiones postprandiales son un poquito complicadas. Bueno, y les pido interés porque realmente lo que viene es un tema muy importante porque son las recomendaciones sobre el uso de edulcorantes en relación a las diferencias metodológicas que existen en los estudios, ¿no? Que es lo que sustenta su uso en los diferentes guías y sobre todo en las sociedades científicas. Bueno, para empezar la sesión voy a presentar al doctor Brian Cavagnari de Argentina, que por vía virtual nos va a dar la charla sobre revisión de guías globales y recomendaciones en práctica clínica sobre azúcares, reducción de azúcares y uso de edulcorantes bajo en calorías y sin calorías. El doctor Cavagnari es licenciado en Ciencias Biológicas y médico de la Universidad de Buenos Aires con especialización en pediatría, doctor en Ciencias Biológicas por la CONICET, máster en Nutrición y máster en Tecnología de Alimentos de la Universidad de Parma, miembro de la Subcomisión Científica de la Sociedad Argentina de Nutrición, donde coordina el curso Alimentación Basada en Evidencia. Finalmente es investigador en la carrera de Nutrición de la Facultad de Ciencias Médicas de la Universidad Católica de Argentina. Una de sus principales líneas de investigación analiza los efectos de los azúcares y de los edulcorantes no calóricos sobre la salud humana a la luz de la medicina basada en la evidencia, y ha publicado varias investigaciones científicas en la materia y participa actualmente en consensos internacionales, conferencias, reuniones de expertos y asesorías sobre la temática. Adelante, doctor Brian Cavagnari.
Muchísimas gracias, doctor, por la presentación. Me gustaría, antes de comenzar, chequear que se esté viendo bien. ¿Se ve bien mi presentación? ¿Y se escucha bien? ¿Hola? Bueno, asumo que se está viendo y escuchando bien. Voy a comenzar. Cualquier cosa me avisan. Bueno, muchísimas gracias de nuevo a los organizadores por invitarme a compartir con ustedes un poco sobre la revisión de las guías locales y las recomendaciones en práctica clínica sobre el uso de azúcares y reducción de azúcares mediante el uso de edulcorantes bajos en calorías o sin calorías.
Se ve perfecto, Brian. Gracias.
Muchas gracias. Muchísimas gracias. Bueno, como corresponde, comienzo con la declaración de potenciales.
I'm going to start with my conflict of interests. You can see here, in several conferences, I have ever received salary as a speaker as part of the International Nutrition Association, which I am part of. So these could be my brief conflict of interest. So let's start with our history, which started about 10 years ago. This is 2015, when the WHO published the guidelines for sugar intake for children and adults, in which they recommend the reduction of free sugar intake, and they recommend that this intake should be reduced by less than 10% of the total calorie intake. As a conditional recommendation, they also pointed out that it would be even better to reduce that to up to 5% of the total calorie intake. So when this was pointed out, many of us, we wanted to see how
la doctora Georgina compartió con ustedes algunos resultados del estudio de Lance, así que no voy a entrar en detalle en esto, por supuesto, pero lo que les quería mostrar es que en los países estudiados de la región, todos, prácticamente todos, exceden estas recomendaciones de la Organización Mundial de la Salud. Puntualmente, el país del cual yo vengo, que es Argentina, es directamente escandaloso.
The results seem to be quite scandalous in terms of how much sugar is consumed, because even though the physicians recommended a 10% of a maximum, Argentina goes by 16%. So we have about 64% of addendum, if you will, of the recommended consumption of sugar in the country. This, of course, will be reflected in several countries of the region. So in the scenario with the recommendations by the WHO and the scenario of a free sugar intake in the region, we need to consider that the replacement of sugar by LNCSS would be the best strategy in order to reduce the numbers, particularly. So everything went well in appearance. However, in the past 2 years, since 2023, once again, the WHO published new guidelines for the use of LMCSs. And an important thing to point out before we go into other aspects of today's relevant topic, and considering that Susana and Rebecca mentioned these things already, it is important to remember that this guideline makes no toxicological assessment. They never updated the maximum levels of intake. So they leave on the wayside everything that should have been considered in terms of safety and science. And they focus mostly on the most clinical outcomes. The guidelines were based on a systematic meta-analysis review that the WHO was in charge of, and they published previously in 2022, in which they analyzed all of the evidence that comes from the controlled randomized clinical assays and trials, and all of the results that come from observational studies, basically cohort studies. And this is where we have the executive summary that is presented as a briefing or summary. Here on the left, what you see is the executive briefing of the results of the randomized clinical studies. They tell you that if you were to replace sugar for LNCLSs, we would have lower body fat, lower BMI, a lower energy intake, a lower intake of free sugar, and an increase of good cholesterol. This is regarding the clinical randomized essays, with a certainty of evidence that goes from low to moderate. When the systematic review analyzed the observational studies, they saw the opposite happening. The intake of LNC is associated with a larger index of obesity, of BMI, with an increased risk of diabetes in time, and an increased risk of cardiovascular diseases. These studies had a certain set of evidence that was low to moderate, so let's keep that in mind. Here's just a summary of what I just showed you, so that we can compare the differences between cohort studies and randomized clinical studies. The cohort studies associated the consumption of LNCSs with the risk of obesity and increased BMI in the long term. However, the randomized trials associated that with a lower BMI and a lower weight, because they are controlled, they happen in the short term. Whilst cohort studies show that the prolonged use of LNCSs was associated with the risk in cardiovascular disease and diabetes. However, the randomized studies show not significant intermediate markers, especially for any type of blood work that would happen. They would show completely different results in function of the design of the study, and we need to consider that too. It is important to also remember that cohort studies can minimize any factor of confusion, but they can never eliminate these factors 100%, especially those that could stem from other studies. But at least you can keep that in mind to analyze for the future. And of course, they can cause reverse causality. And there's an example when I see an association of LNCS's intake and a larger body mass. Is LNCS consumption the thing that leads me to an increased body mass, or maybe the fact that I have a larger body mass allows me to choose lower calorie foods that have LNCSs? So this is what we would normally call a reverse causality. And as a classic axiom, these studies can show an association, but they can never actually show a causal relation, whilst controlled, randomized trials are the types of studies that show the best evidence of a possible relationship between cause and effect. And this is why the pyramid of evidence shows them way up compared to observational studies. Now once we have clarified this, what truly caught our eyes is, well, you need to think of what you might consider what the WHO thought would be part of their guidelines in order to make these recommendations. Well, basically, they discarded entirely the evidence of the clinical randomized studies, and they pointed out that these studies were done in the short term, and they were based only in the observational studies that have lower levels of evidence inherently. So after they discarded the clinical studies and based themselves only on the observational studies, the WHO suggested that these LNCSs should not be used as a medium of weight control or to reduce the risk of non-transmissible diseases. And of course, this happened due to the lower level of evidence, and it was conditional in the end. So we find ourselves at a moment in which we have two recommendations that might seem as if they would be mutually exclusive, because they would say, well, we need to decrease the consumption of free sugars, and they decided to develop a tool that would allow the scientists to recognize whether a population likes certain types of flavors. And now they find themselves, however, in a point in which they need no longer to incorporate the use of LNCSs in the long term. So the question came up. What popped up is, well, there's this condition in order to diminish the consumption of the sugars that is conditional, but there's also this condition of not incorporating the LNCSs in products. So in this dichotomy, we might find any deleterious effect. Well, we had the first few red flags that were raised by the Australian Health Department, and they said that the LNCSs in long-term consumption will have deleterious effects, especially for general health. And this is based on common sense. If I'm being told that I can no longer eat sugars, but I can also no longer use LNCSs, and I like sweet tastes, which one will I end up choosing? I will end up choosing sugar in the long term. And the advancement that would have happened with LNCS is something that normal consumer would not consider. I would want to go into detail, however, into the recommendations as to what whether they would be conditional or not. A strong recommendation, for instance, is when you expect the consequences for implementation would be desirable and they would go over the undesirable consequences. For instance, if I consume less than 10% of sugars, the fact that I consume less than 10% sugars allows for the recommendation to measure better outcomes. So when it is a strong recommendation, you might end up adopting the recommendation as a public policy in most of the situations. However, in a conditional or weak recommendations, well, I'm not entirely sure as to what are the desirable consequences of what could happen. What I just told you, if I were to implement the LICS recommendation, would it be better than not recommending it? Well, that depends, because if I end up going back to sugar, things won't be better. So by definition, When a recommendation is conditional, unlike a strong recommendation, in order for that to be created into public policies, they require substantial debate with the participation of all interested parties. And this is where I want to share with you briefly an example of what happened in Argentina. These are studies that were done by our task force in which we measured on the one side sugar consumption and on the other studies we measured the LNCS consumption. And what's the situation in Argentina? Like I told you, in Argentina we see a consumption of over 60% of what is usually recommended. And 79% of the population, adult population, do not comply with the recommendation, a strong recommendation by the WHO. If we were to go to the 5% recommendation, about 95% of the adult population in Argentina would not comply with this particular recommendation. So this is a country in which a lot of candy or sweets are being consumed. When we decided to create a study, we understood that only 42% of the population ended up consuming LNCSs, and so that means that for instance, for most of the population, ADI doesn't actually reach the levels that we would have wanted for LNC consumption. So we find ourselves in a scenario in which we have a strong recommendation in a country where we have a lot of sugar consumption, but we also have a conditional recommendation in a country where these types of sweets are also consumed. So we need to keep this in mind. And a few statements were released by the government, especially in countries with a high prevalence of obesity and overweightness, like ours, that is Argentina, in which it is recommended that you should no longer be consuming that much sugar. It is important to count with a tool, even if it is in the short term, so that the patients cannot go back to consuming as much sugar as they should. And if we're going to have to re-educate the flavor tasting buds, if you will, of the population as well. So what would the Dietitian Association of Argentina said? Well, they said that until a strong recommendation is actually being pointed out, it would be considered important for implementation as public policy. That, of course, includes normal things like drinking more water, eating less sugars, and etc. And what did the Argentina Federation of Diabetes said? They pointed out that because of the amount of evidence of safety use for LMDCS, they will continue to be the best selection against sugary products in prevention and care for diabetes. The Argentina Association of Nutritionists, of which I'm part of, and they said until we have high quality evidence, we consider that LNCs as used in moderation and would be recommended to continue to be consumed to your sugar-related disease. So this is an example in which we see that most of the strong recommendations can be taken into public policy in Argentina, but when they are conditional, you need all of the evidence available to make sure that they can be brought into public policies. And this is how the many different government entities start offering their own opinions. So in order to provide a summary, well, we started 10 years ago with the recommendations on decreasing free sugar intake at least by 10% of the total calorie intake. When we found ourselves in this scenario, a lot of associations and federations and agencies, like you see over here, the Mexican and Argentinian associations, Diabetes Canada, the United States government, all of them decided to create statements and consensus and declarations on the use of LNTSs and sugar. And generally speaking, they all go in the same line. They ascertain that it is safe. LNCSs can be used in any stage of life for all forms of physiological states or pathological states. And they pointed out that the use of LNCSs as replacement for sugar can be used in order to control weight loss. But what happened after the fact? Like I told you, about 2 years ago, we saw these new guidelines and the recommendations for the use of LNCSs, and all of the statements that were published beforehand, from 2016 and over, will no longer include the positions of the WHO and therefore would be considered no longer updated. for those of us here, because we represent any type of Latin American association, that would mean that we would have to go back to the table and create new studies, new statements, declarations, especially when we have these new body of evidence that's wrong, in order to update the types of articles that were published beforehand. The invitation, however, is for you to consider what happened in the past 2 years. In the past 2 years, very important entities like the one that you see here started to talk and to raise their voice. And I'm going to share with you the most important points of these entities and the new positions that they have taken. The nutritionist and diabetes group for Europe says that the intake of free sugars needs to go below 10% of the total calorie intake. And we clarify that LCSs can be used to substitute um, as a substitute for weight loss or other types of approaches. What did the American Diabetes Association said? They said that they suggest people suffering from diabetes or risk of diabetes to use LCSs instead of sugary products, especially when they are used in the short term and in moderate quantities in order to reduce their total calorie intake. And what does the British Diet Association say alongside several studies that they carried out? And what they say is that in 2025, LCSs can play a role in the management of weight loss and diabetes, although they do not represent a independent solution because we need to consider other implications like lower consumption of fats and a balanced diet. Of the Latin American associations, the only one that actually made a statement was the Brazilian Association alongside the Diabetes Attention Center in Brazil. And what they said is that on the one side, the use of LCSs is safe. That includes children, gestating individuals as well, and can be used by any institution. They also said that the use of LCSs can even help in reducing total calorie intake. And at last, but not at least, this is a government entity, which is the Scientific Advisors for Nutrition Center, the Office for Health Improvement and Disparities, which is part of the UK government. And they punctually said the following as to what the WHO pointed out. We said that the WHO gave greater weight to cohort prospective studies than others. So they say that they rather have that randomized clinical studies because they tend to prove better than the others. And we can say that the use of sugars, specifically LNCS, is great for weight control, weight loss control. So they recommend that for children, it's better not to use any of these substances. And for teenagers, by substituting these types of substances can help them in their development. However, the long-term objective is to limit the use of both sugars and LNCSs. These are all clarifications by 2025 in which we see the countries giving their opinion. So to conclude, I'll tell you the following. Several observation studies, specifically prospective cohorts, point out that the use of sweeteners is associated with greater BMI, risk of obesity, diabetes 2, and cardiovascular disease. On the other hand, the clinical randomized studies, which tend to be on the shorter term, they show that the use of LNCS is beneficial because they allow us to have lower sugar intake, a better BMI, and a better weight in general. And the guidelines of the WHO that say that LNCS should not be a medium of weight loss control or the reduction of non-transmissible chronic diseases were only based on observational studies without taking into account randomized studies that provide a greater body of evidence. So they took taking a public policy from a recommendation that is firm compared to one that is transitional is harder, and it needs to function into the local realities of the countries. That is why several patient and medical associations still consider that it is important to have a tool that could be in the short term so that those individuals that are suffering from obesity or diabetes can decrease the consumption of free calories in their diet. Thank you very much. Thank you, Doctor, for your presentation. Now we're going to hear from Dr. Hugo Laviada-Molina from Mexico. The doctor is going to talk about the effects of LNCSS and evidence-based and systematic reviews, recent systematic reviews. Dr. Leviada is a surgeon by the Autonomous University of the Yucatan, endocrinologist of the National Center for Endocrinology, 20 de noviembre. Is a Master of Medical Sciences and Endocrinology by the Sheffield University. He has performed as clinical specialist at the IMSS and in the private sector as well. He currently works at the Humanity Hospital in Mérida, where he does clinical research in pharmaceutical research. He's author and co-author of over 100 papers, including consensus work and meta-analysis on LNCSS. He also coordinates the obesity task force for the Nutrition Center in Mexico, and he's a researcher, professor of the Marista University in Mérida, and member of the National System of Researchers in Mexico. Dr. Laviada, the floor is now yours. We're going to try to comply with the challenge of talking meta-analysis, which tends to be quite a challenging topic. And when you say lots of information, it tends to become a bit overwhelming. So I want to focus mostly into the aspects that are part of our problem, basically, and try to answer a little bit of the questions that we might have asked ourselves, especially for the decision-making process. This is my conflict of interest. I have received salaries from some of these companies that you see here, some of which boast LNCS products. However, they had no participation in the preparation of this presentation. We are going to start with a specific topic that has been at the center of the debate, which has to do with the use of LNCSs during pregnancy. And after their consumptions, they might come into outcomes that have to do with lower weight of the baby or a decrease in gestation. Well, this is a piece of evidence that was published in 2021. We had a few previous studies related to the body weight of babies of individuals that were consuming LNCS, and they saw there's a relationship there of weight loss as well, for the mothers at least. And if we were to look into the global effects of these 4 cohorts, it might seem as if there's an increase by 18% of risk in this case of pregnancy being happening earlier, of birth happening earlier during pregnancy stages. And in order to show to you what's happening, there was a report of increase that was statistically significant for children that were born from gestating mothers that were consuming LNCS, and we showed how there was also a decrease in weight for these babies. And it is statistically significant, at least for these types of cohort studies that we carried out with this particular design. Now, to show to you the problem that we have at hand on observational studies, well, and factors of confusion, well, when you were to divide, for instance, preterm pregnancy as a general outcome for most women, and we see in panel A, those that were consuming LNCSs during pregnancy, and maybe we have those that would have more than one portion, 2 to 3. In panel C, we have those that would consume over 4 portions of LNCSs during the day. And we see that those that had more social during the day, we see a loss of statistic significance, which it might seem obvious, especially when we are considering the criteria for observational studies. We need to remind ourselves that gradient of dosage needs to be considered as key as well. So gradient of dosage compared to outcome should be considered as well. So we need to think about those individuals that are consuming no LNCSs and they provide significant numbers, whilst those that consume a lot of it provide no significant variables. And we need to balance out these two aspects, as maybe perhaps the design of the study did not allow for the elimination of these confusion residual factors, of which Dr. Cavagnari actually talked about in the observational studies. So the possibility of residual compression factor due to the same tends to be high, especially in just models where the studies included. There was no analysis of relevant aspects in this case, like, for instance, family history, which and we had to be create adjustment models, to decrease BMI and there are, however, many other important aspects in the genesis of alterations during pregnancy that, like, for instance, during birth, that aren't analyzed in these studies. So the adjusted models tend to be more exhaustive in nature, but they don't usually end up eliminating the confusion factors or reversed causality that was mentioned beforehand. And authors don't analyze the lack of probability that they can come into negative outcomes, and the authors don't actually recognize that that weight during birth tends to be irrelevant, but it's not statistically significant due to the magnitude of the problem. So we're going to go deeply into cancer, which has been a rather heated debate, if you will, since 2023, when we had this very hot summer. We had two organizations joining efforts: the GECFA and the IRC, the joint efforts. Dr. Sokolowski and Dr. Susana have already talked about them, and they published studies after June of 2021, and they considered all of the information relevant so far. The JECFA pointed out that the proof between the consumption of aspartame in cancer turned out to not be convincing for the committee. However, the IIRC concluded that aspartame is a plausible human carcinogen element. Group 2B, at some point, coffee was even included there, but still in a review. For instance, even cell phones were considered at some point, or lead-free gasoline can even end up causing cancer. So there's a lot of speculation here that's happening, but it is suggested by certain studies that could end up creating some sort of uncertainty at some point. And this is how they are classified. And based on 3 studies of over a dozen of cohorts, 2 dozen of cohorts. And actually, those 2 dozens, they showed no conclusion of evidence of cancer. However, these 3 studies are the ones that were ended up being conducted. And they are based in a subpopulation of diabetic patients out of the entirety cohort that ended up being statistically significant in order to suggest liver-borne cancer, and which is another aspect of Sweetener tests. Many studies suggest that certain determined substances favor specific cancers, but it turns out that in other cohorts, they have nothing to do. So this is something that also needs to be analyzed. At least the Work Task Force concluded that we cannot discard the possibility of a risk of causality and bias in cancer risk for patients that consume LNCSs. So, cancer tests for humans are still considered limited and insufficient for any type of cancer, including liver-borne disease. And in this case, I point out that we are talking about aspartame. And I want to remind you of the risk factors that are associated to cancer. You see once again adiposity, obesity, in this case, the metabolic syndrome, which is associated mostly to this hepatic steatosis with or without diabetes. Also the use of alcohol for hepatitis C. But I do want to center on the blocks that you see here. One of the studies that shows the baseline for this conclusion. This is the baseline of basal data for one of these three studies. And in this basal data chart, you can see that the use of LNCSs increases by threefold with diabetes populations. In this cohort, here we have the people that don't use LNCSs, and then those that do use, and how we can see an increase by threefold of the presence of diabetes amongst those that actually use the LNCS. Something that might seem reasonable, but when we compare populations that tend to be different. And diabetes is a metabolic syndrome that is associated to liver steatosis and an increased risk of liver cancer. You can see here with an increase of IBM shows a greater risk of chronic diseases. This has been shown by previous professors who actually show that the more users of LNCSs tends to show a greater risk of chronic diseases as well. And this makes us think that regardless of that, you can have adjustments in the basal data, you can always have residual effects there too. This is a recent meta-analysis
that evaluates the risk of cancer. And there is no association to cancer. However, there was a relationship with the general increase of mortality, and not just by any reason, and not cancer. And this mortality rate signal what Dr. Brian said before, where participants with a higher intake of LNCS are more prone to be obese, hypertense, to suffer from dyslipidemia, and this might lead to a higher mortality, not because they're using LNCS, but for the pre-existent factors they already have. And this is the eternal debate that we have with cohort studies. Also recently, this French study, you probably heard about it, it's the Anayanet study that showed a relationship with cancer. This is a very specific cohort because they got the data online, and these are women of a high income group of women. They showed this trend from the breast cancer related to aspartame and acesulfame. And when we take a look at a meta-analysis, the evidence of better balanced cohorts that were more representative of the population, we see that this is not consistent, the result regarding breast cancer. Actually, the same WHO committee did not consider breast cancer and just consider the hepatocellular cancer, and they still question it according to the design of the studies, and that in some of them they were based on subgroups where they had diabetes. And now let's talk a little bit about obesity. Obesity is the main generator of metabolic syndrome and many other diseases that would increase the likelihood. And in our work, what we see is what happens in control trials, where the main comparison is sugar, table sugar. We will see that there is a weak effect, but that is statistically significant with the ones that use LNCS and sugar. And this makes us think that this effect is only related to the substitution of sugar when we compare control trials to non-caloric comparison elements like water, placebo. What we see is that the effect is completely neutral. LNCS doesn't have any characteristic that favors weight loss. Is just because they are saving calories in the ingestion. This is the meta-analysis for children. And when we take a look at this, if this could favor obesity, what we see is a trend. In controlled trials, we substitute sugar. There is a discrete trend that was not significant here to reduce weight. Here is another group, a group with a group in Harvard. The children aspect has a lot to do with the labeling. So we have a meta-analysis where we had controlled and uncontrolled trials, only observational research. When we talk about controlled trials, we see exactly the same as we see in adults. It's a statistically significant trend to reduce weight, but with a very weak effect, because you do not expect that reducing sugar shows a relevant weight loss. And in observational groups, what we saw is something similar to what we saw in adults. It was not statistically significant, but when we see the trend goes to the right way, about it being significant. Here it doesn't seem to have an effect on kids that favors obesity. So the effect of substituting sugar, we will see it in people who suffer from obesity and not with people who are lightly overweight or within normal ranges in their weight. And finally, this is a work in progress. It's been shown as an abstract still, and it has led from Alan Espinosa, alumni from this university, and he's in Harvard right now. The following doctor will give us more detail about this. This meta-analysis is to take a look at this meta-analysis, taking a look at cohorts that have sequential evaluations. The issue here is that the exposition evaluation can be over or sub-estimated if we think that at baseline we assume that they will be consumers throughout their life, or that non-consumers will still be non-consumers throughout their life. So if we have substitution models where subjects are evaluated with the real consumption trends, and we have an analysis, mediation analysis, where we explore how they avoid sugar beverages. So what we will see is that even in observational groups, we have several findings. We will see a slight decrease in weight when subjects increase the increase of LNCS and they substitute it for sugar instead of sugar beverages, for example. When we replace SSBs with ASBs, We have a reduction in weight that is more notorious. When we replace SSBs with water, we see something similar than what happens with SSBs. And the only detail that we see here is when we replace SSBs with water, we see that in women, it seems to be even more effect than ASB. This hasn't been explained clearly. And we don't know if it's present in different cohorts. It seems that not even in cohorts or observational studies, we cannot see that LNCs are associated to an increase in weight. So it seems that the significance for these entities are also erased. Thank you, Dr. Laviada. Just to wrap up this afternoon session, we will listen, and we have the pleasure to listen to Dr. Sievenpiper. I don't know if I'm pronouncing this right. He's from Canada. He will have an English conversation with us. We are talking about advanced methodologies to overcome limitations in research. Dr. Sievenpiper is a clinician scientist, and he holds an appointment as a professor at the University of Toronto, as well as a staff physician and scientist at St. Michael's Hospital. He has established an international recognized research program that focuses on using randomized controlled trials and epidemiological approaches to address questions of clinical and public health importance in relation to diet and cardiometabolic disease prevention. The recipient of numerous awards, he is directly involved in the development of clinical practice guidelines for obesity, diabetes, and cardiovascular disease when planning to export communities in Canada and Europe. He has written over 300 papers and was recognized as a highly cited researcher 2023 and 2024, being in the top 0.1% of researchers. Welcome, Dr. Sievenpiper.
Speak here, or do I speak? This one's okay? I prefer the microphone. Oops. It's not working, is it? Okay, well, thank you very much for that kind introduction. Thank you very much to FNUT and to ISA and all those that brought us together, I think, for this really important meeting. I've really enjoyed the talk so far and look forward to our next sessions. So I think Brian and Hugo very nicely set up my talk in terms of where we are with the guidelines, and Brian doing that nice summary and really telling you about the evidence that underlies that, which is really the basis for this, and then a really nice review of the existing systematic reviews and meta-analyses and limitations there, both of which really feed directly into what I'm going to talk about in terms of advanced methodologies to address the research limitations. We already got a taste of that with the Harvard cohort analysis that's being led by Alan Espinoza, a graduate of this university and really strong researcher in this area. So always a pleasure to come and share some of our thinking and research. These are my disclosures. I've been trained by my mentor, David Jenkins, so I cite everything from financial to familial to intellectual, and I'm involved with a lot of guidelines where we've certainly provided recommendations as it relates to low and no calorie sweeteners and companies that have low and no calorie sweeteners in their portfolio where I've done talks or they've provided foods for our trials. So I'm going to start, you've already seen this slide, and this is a slightly different way of showing it to you, but really this is the basis for my talk in terms of, I think, what's led us to really want to bring forward some robust advanced methodologies to address this question, just because of how influential I think this guideline has been and how much confusion it's sown. So this is representing the commissioned systematic review meta-analysis that was the basis of the WHO guideline, as Brian pointed out. There was actually two of them. There was one in 2019, and then there was this one in 2022. The one in 2019, they it was much more limited in terms of scope, in terms of the trials and also studies included. And their analysis plan didn't include some of the things that they did here that we actually were part of helping to develop with Jason Montez, who was one of the leads on this commission review. So it showed that in the RCTs, where low and no calorie sweetened beverages are substituted for sugar sweetened beverages, you see reductions of body weight, BMI, energy intake, and sugars intake. But in the observational studies, where you have this issue of baseline prevalent exposure analyses that was pointed out in the previous talks, you see really the opposite. You see increased risk for obesity, BMI, increased risk for diabetes, coronary disease, cardiovascular disease, and mortality outcomes, in particular all-cause mortality, which is particularly concerning, bladder cancer and premature birth. And this is the interpretation of that. Now, part of that guideline, and I just want to go back, is that they did rate the evidence as low to moderate certainty for the RCTs, and this was pointed out by Brian, and they rated the evidence for the prospective cohorts as very low to low using the GRADE approach, which is the framework that was used and WHO uses for all of its guidelines. And the conclusion of this did give more weight to the randomized controlled trials. But when it was sent to the NUGAG committee at WHO, they interpret it differently, and this has been well discussed by Brian in his slides, so I'm not going to go through it, but I'm going to give you the actual wording that was put in that interpretation, that the discordant results, and this is always an issue in nutrition when our RCTs don't agree with our cohorts, and where we want to see that agreement between intermediate outcomes and those big patient-important, public health-important outcomes. So those discordant results in this case, instead of really being a cause for concern in terms of some of the methodologies, they used to dismiss the prospective cohort studies, giving more weight, the randomized controlled trials, giving more weight to the prospective cohort studies and the harm that was seen there over the benefits that were seen over the short term in the randomized controlled trials. And the recommendation you get is not to recommend them. One thing I want you to note in the recommendation, which I think is particularly relevant, is the wording. And in nowhere in that recommendation do you see any mention of sugars, which is a necessary context. And if you look at other guidelines where, and I'll get into this a bit, where we've seen recommendations in favor or supportive of low no-calorie sweeteners, that context is always there. So I think that that's an important distinction here. It was left out. It was just the use of sweeteners for a risk of non-communicable diseases and weight management. So what is the consensus among global guidelines? And we got a beautiful narrative overview from Brian of that. We've gone a step further. So we actually did a systematic review of global guidelines, and it really just shows in numbers, which I think you would have gathered from Brian's talk when you look at it. If you compare the public health dietary guidelines, of which WHO is one, these are the dietary guidelines from national dietary guidelines from countries, compared with clinical practice guidelines, you see a stark difference. So the clinical practice guidelines are really universal in recommending low and no calorie sweeteners. There's just one exception. That's actually, that 4% is just one guideline, which was an inflammatory bowel disease guideline. All the diabetes, obesity, cardiovascular guidelines favor the use of low and no calorie sweeteners. So almost a near universal agreement among those that had a recommendation or mention of low and no calorie sweeteners. For the prospective cohorts, 47% recommended against it, only 37% supported it. But what's important to know, the 37% that supported it, those such as SACN, we saw a number of other, what would be considered dietary guidelines, they have that necessary context of sugar. The other, I think, really important issue, and it came through from Hugo's talk, and I think we're understanding, is also the evidence base on which they are relying. So both sets of cohorts would have looked at cohorts and trials, but if you looked at the clinical practice guidelines, they give more weight to the randomized controlled trials. So if you read through them, they all have the necessary context of the substitution, and they all give more weight to randomized controlled trials, which is really the convention in systems of evidence-based medicine. And that really probably represents those that are the guideline makers and their background and their training, as opposed to the more public health guideline makers that you're going to get with the public health guidelines, where there was greater weighting of prospective cohorts. So in every case where we see in the prospective cohorts they rate against it, they're giving more weight to the prospective cohort. So I think that that's important in really setting up the discussion, that the epidemiology right now drives most of our nutrition guidance, our public health nutrition guidance, but in particular in this case, this is highlighting it, it's really the reason that we have this discordance, if you like, between clinical practice guidelines and public health guidelines. And I think it's an important distinction, and something Hugo actually taught me in one of his presentations, where really separating out, I think, the different types of guidelines, clinical practice versus public health guidelines. Another point to make is likely that number is underestimated. So there's only 108 countries that have dietary guidelines out of the 193 plus 2 observers of the United Nations. And the others would be using the WHO guideline. So likely in that case, because those countries don't have ability to have their own guidelines, they adopt the WHO, that number is probably more like about 66%. So really showing a stark difference between the two. So I just wanted to spend some time on that, and I think it very nicely shows in a pie diagram, a summary what I think Brian showed you in his narrative overview. So how does one reconcile the evidence from RCTs and prospective cohorts? And now this is a question we had as guidelines makers. So I was part of the clinical practice guidelines issued by the EASD in 2023 that Brian showed. And if we looked at the landscape, and we were part of that, Kees de Graaf, Hugo, and others were part of a number of these statements, consensus statements, letters to the editor, commentaries, editorials, there was really a call, coming out of a lot of the confusing results we were seeing for better research methods in this area, more robust methods, in particular as it relates to trials and that context in terms of displacement of calories. There were a number of meta-analyses that had put together trials that had substituted low-calorie sweetened beverages for sugar-sweetened beverages with water, placebo, or matched weight loss control, where there's no caloric displacement, and you wouldn't expect to see any changes in weight or energy displacement. So actually ensuring that the nature of the comparator is appreciated and respected, but also the prospective cohorts where there's this real issue of reverse causality, which has been very well described, so I'm not going to go in it, but that is well documented in the prospective cohorts themselves. The authors and investigators cite it certainly in their limitations. The systematic review meta-analysis groups that do those analyses cite it in the limitations, and the guidelines makers do, and certainly all of these statements do. So this is a very well documented concern. So taking that forward, we were developing the guidelines for the EASD, which were shown by Brian in 2023, and we commissioned a series of systematic reviews and meta-analyses that directly responded to these criticisms to advanced research methodologies to ensure we were getting the best estimates in terms of low and no calorie sweeteners. And this was part of the carbohydrate chapter, and you saw the recommendation in Spanish that Brian provided on his slide. We used the exact same framework that WHO did, and I think that's important. We used GRADE, that's the approach that we're using for our ESD guidelines. This gives a higher weight to randomized controlled trials. When we think of bias, we think of the units of analysis. So randomized controlled trials have the best protection against bias because of that random allocation of prognostic factors that it comes with randomization. And then below that, we would have observational studies, the best of which would be prospective cohort studies. And then we apply which start as low. And then we have a series of downgrades and upgrades we can apply to the evidence to bring the RCTs down from high and the observational studies up from low, or to bring them all down depending on the issues. So what is the evidence from randomized trials? So this was work which was led, and the method development was worked by my postdoc at the time, now research associate Tosif Khan, and a very capable master's student named McGlenn. When we defined this with the guidelines committee for the EASD guidelines, we wanted to really define it in the context of 3 comparisons of clinical and public health importance, and those have been laid out very nicely in the Harvard analysis. 1, low no-calorie sweetened beverages for sugar-sweetened beverages, the intended substitution with caloric displacement, and we've heard about sugars and added sugars and free sugars and sugar-sweetened beverages and the need to displace those calories. Water for sugar-sweetened beverages, we called that the standard of care substitution, since all guidelines recommend water as the first step in terms of displacement with energy displacement, so matched. And then low and no-calorie sweetened beverages for water to get at that reference substitution. Importantly, because of matrix effects, if you're using sweeteners in solid foods because you're displacing grams of sugars with milligrams of sweeteners, you necessarily get other ingredients coming up, and usually it's backfilled with refined starches, maltodextrin, so the energy doesn't really change. So we wanted to look at a single matrix, so we chose beverage, and we chose that also very purposefully because beverages represent the single most important source of added and free sugars in terms of guidelines for sugars reduction, and beverages also represent the single most important source of low and no calorie sweeteners. So we thought that this was the best way to look at this question. We also use something called network meta-analyses. That's used a lot in meta-analyses of drugs, where you can use a common comparator where you don't have a direct comparison to look at the indirect comparisons when comparing to increase your information size. So we can actually bring more information. It was really building on the meta-analysis that Hugo showed you, that was in 2020, also that of Peter Rogers and others that had purposefully done this substitution to take into account the nature of the comparator. So what did we find? Well, we found very similar to what Hugo did and showed in his meta-analyses, and we published this in 2022, about a month before the WHO came out. And we actually shared this with Jason Montez, and was one of the reasons they made some of the adjustments and the substitutions for sugars in their meta-analysis. And we show that if you're substituting low and no calorie sweetened beverages for sugar sweetened beverages, you see a reduction in weight, adiposity related and weight related outcomes, and importantly, no adverse effects across 20 intermediate outcomes, which were pre-specified by the guidelines committee across all of our commissioned reviews for the guideline, not just for this one. When we look at the standard of care substitution, water, first of all, no harmful effects as we would hope and expect. The peer reviewers and editors were quite surprised we didn't see anything. We didn't see any benefits, but I think that this relates probably to the fact that we had a very few pairwise comparisons, direct comparisons, that relied a lot on indirect comparisons. It may also be one of adherence and other issues that have been raised if you're trying to transfer a sugar sweetened beverage consumer over to an alternative product, but no harm, and generally everything going in the direction of benefit. Now, what about the reference substitution, which I think is important, and this is the one I think in the UPF debate that Montero wants. He wants his products compared to the low UPF version, and water would be the low UPF version in this case, although it is maybe fluoridated and other things, and we can talk about that. But and in this case here, we see the first thing is no adverse signals. Now, we do see some green and red. What that means is the low and no calorie sweetened beverages were a little bit better for body weight and systolic blood pressure, and the water was a little bit better for HbA1c, but both went in the same direction. Both showed benefit. There was just a little bit better for the low and no calorie and a little bit better for the water in the case of HbA1c, but overall no adverse signals. So when we took all of this together, it suggested that the benefits we see with water do hold for low and no calorie sweetened beverages, and we see comparable effects, and they do represent a strategy that can be used, and that's why we have the guideline as we have it, from the standpoint of the randomized controlled trials. But what about the prospective cohort studies where we have these signals going the wrong direction? So for this one, to address the methodological issues that were discussed about reverse causality, there's been a series of methodological papers that show that you get more reliable, robust results that are closer aligned with what you see with randomized controlled trials, especially as it relates to weight outcomes. This is some methodological work done by the Harvard cohorts. If you use change analyses versus lag or baseline or prevalent. So most cohorts are using baseline or prevalent, which means they just do one exposure assessment at the beginning, and then they follow them over a long time, and then look at the outcome. And Hugo described this. That's assuming that diet's not changing. It's assuming that everything has remained the same. Not a lot of cohorts have it, but a number of cohorts do have repeated measures. The Harvard cohorts do their FFQs every 4 years. And when you look at those results from repeated measures, you tend to see results that, again, more reliable, more robust, more in line with randomized trials, more biologically plausible. So we pre-specified change analyses. We also noticed in looking at the literature that you get better effects that agree with randomized trials, but it's effectively setting up a randomized trial within a cohort if you use substitution analyses, because it's treating it like an intervention with the substitutions. So we set up those same 3 pre-specified substitutions. And we mandated that all analyses had to be adjusted for adiposity, which can help to mitigate against the reverse causality and some of the variables that Hugo was showing. So when we did that, and we look at the intended substitution, you actually see data that aligns very nicely with the RCT evidence. So unlike the increases in risk that we saw with the baseline prevalent exposures that were seen in the WHO review, here you see associated reductions in body weight, obesity, coronary heart disease, and some very important ones, cardiovascular mortality and all-cause mortality. So here we're seeing the opposite of what you see with baseline prevalent exposures and outcomes that directly translate from what we see in the randomized controlled trial evidence. So good agreement and no adverse signals, importantly. If we look at the standard of care, water, here we do see benefits. So in substituting water for sugar-sweetened beverages, we see associated reductions in body weight and waist circumference, body fat, obesity incidence, and diabetes incidence. Those are all the outcomes they have. They don't have mortality in others, but here you're seeing associated benefits. And we look at the low and no calorie for water, that reference substitution, we see no differences. So we see here very nice agreement with the randomized controlled trial evidence. And putting this together with the randomized controlled trial evidence allowed us to come to a conclusion of moderate certainty for a benefit of substituting low and no calorie sweetened beverages for sugar sweetened beverages. We also looked at the change analyses. Here we're very limited because there's not very many cohorts that have these repeated measures. The Harvard cohorts are the main one, the 3 Harvard cohorts. There's a couple of others. And what you can see here when you model change, this is over time, and look at body weight and waist circumference, we see associated reductions in those. So we see, again, agreement with the substitution analyses and agreement with the RCT evidence. And so that really led us to the conclusion that and recommendation we had. Now, how do these estimates compare with those of the commissioned review from the WHO? So Tosif Khan led this paper and very nicely laid them out so they were in a visual. And you can see the estimates from the WHO are basically the estimates in red where you're seeing increased risk, and the estimates in green are showing no harm are from our substitution and change models. So you're seeing the opposite of what was seen when you're using baseline or prevalence. So how we model exposures matters, and we need to be thinking about robust methods. Now, is there a WHO precedent for prioritizing the evidence from substitution analyses? I think that's important if we're going to say that WHO should prioritize this approach. Well, they actually did this, and it's a very nice illustrative example for saturated fat. They commissioned a review in 2015, led by my good friend Russ D'Souza at McMaster. And they didn't have the method development for substitution, meta-analysis of substitutions at that time. So they just looked at the baseline prevalent exposure assessments, and these were the prioritized WHO outcomes. And you can see there was no association with saturated fat across those outcomes. Now, it was noted in the discussion that the substitution does matter. You need to be thinking about the replacement. And we know that certainly from the randomized controlled trial evidence in terms of what you substitute for saturated fat to get a reduction in cholesterol, for example. And it wasn't until 2023, so it took 8 years, we may have to wait 8 years, that they came out with a second commission systematic review, which was the basis of their guideline that came out in 2023 on saturated fat, where they showed that substituting polyunsaturated fat, monounsaturated fat from plant sources, and whole grains and low glycemic index carbohydrates was for saturated fat reduced cardiovascular disease outcomes. So this really shows you the method development and how it's being, I think, certainly embraced and endorsed by WHO. So what is the path forward? Well, what we've done is we've taken on a mega cohorts pooling project. So we're taking cohorts that are only over 100,000. We have funding from Diabetes Canada to support this. We got a grant. These are the 10 cohorts that actually have data on low and no calorie sweetened beverages, sugar sweetened beverages, and water. And these are all cohorts that have over 100,000 to get the best estimates, the most representative estimates, including the Harvard cohorts where we saw the analysis that was done by Alan. And we are going to apply this in this pooling project. And what I'm going to share with you is there's 2 phases to this. So this is an individual patient level data meta-analysis. This has the benefit of allowing you to standardize your adjustments and your entry criteria so you can actually improve the precision of your estimates. So you actually get more precise, more robust estimates because you're standardizing the protocol and how you're analyzing it across all of the cohorts, across their FFQs, across the confounder adjustments, and so on. So this will be the individual patient level data meta-analysis, but we've undertaken as a first project, which we're just writing up, and we're just now finalizing the analysis of these cohorts, which is to look at the aggregate data. You can do something called a meta substitution. This is a method development which takes the estimates from where we have them for low and no calorie sweetened beverages and sugar sweetened beverages and water, and we can actually impute substitutions where we don't have them. And what we see here is very similar to what we showed in our diabetes care meta-analysis for the commissioned review. We see the benefits of substitution of low and no calorie sweetened beverages for sugar sweetened beverages, associated reductions in body weight, diabetes, and also cardiovascular mortality, all-cause mortality. So we see the same thing that we're seeing there, but importantly, we see diabetes now. We didn't see diabetes before, so now we have a more robust estimate for diabetes. We actually see a reduction in diabetes, which is similar to what was seen with water. So this is the first step in this project. It's looking at study-level data, so it's the aggregating of study-level data, which we'll publish with the PIs. And I think that this will be important too, because all of the PIs of these cohorts have signed on and are endorsing this as the most robust method, which I think is important going forward for being able to really, I think, move the field as it relates to the epidemiology here. So with that, I'm just going to give you my conclusions. So the example of low and no calorie sweeteners and health outcomes shows the importance of accounting for the nature of the comparator, both in randomized trials and in cohorts. So caloric versus non-caloric comparators and displacement of calories. We have to follow the calories for appropriate inferences of effects from randomized trials. And for really looking at exposure assessment methods, more robust methods in our prospective cohorts, looking at substitution change over prevalent or baseline approaches and adjusting for adiposity for mitigation, reverse causality, and residual confounding. When we do that, if we look at network meta-analyses of RCTs, we see the intended benefit of substituting low and no-calorie sweetened beverages for sugar-sweetened beverages. It leads to weight loss and improvements in weight-related cardiometabolic risk factors, similar to water. When we look at the prospective cohorts, we see that these outcomes are now concordant, not discordant, to use the WHO language, and they do show a translation of those benefits to those big patient-important, public health-important outcomes, such as diabetes, such as cardiovascular mortality and all-cause mortality, again, similar to water. So I think we get a nice alignment, and the upcoming mega cohorts pooling project, which leverages more these robust methods, I think will be important for further reconciling these differences and hopefully driving advancement in terms of the appropriate weighting of randomized trials and the appropriate weighting of cohorts and appropriate analyses for future guidelines. Just want to thank my incredible team and thank you for your attention.
Bueno, muchas gracias, doctor Sievenpiper.
Well, thank you, Dr. Sievenpiper. Excellent conference with lots of information, and it makes it very clear in the path to follow for following your research. So let's go to our Q&A. I would like to invite Dr. Mónica Hurtado from Mexico, Dr. David Fernando López from Colombia, and Dr. Anayanet Jáquez from Dominican Republic to come up to the stage. Dr. Hurtado, she's a nutritionist in the University of Burdeos and Navarra. She's a doctor in diabetes, co-author. She has different titles. She's also a teacher and a communicator in different media. And she has a platform of I Want to Know, or Quiero Saber platform, and she works in Diabetes Association. Dr. David Fernando is a coordinator of clinical research in the Nutritious Institute, dietitian in the Colombia Institute from Ciudad del Bosque. And he is also part of the University of Savannah. He has 15 years of experience in the research industry, and he has been the editor of the book Applied Nutrition in Chronic Diseases and different articles in scientific public journals. And finally, Dr. Anayanet Jáquez, she's a physician in biomedical physician. She's graduate of the Pontificia Madre from Dominican Republic, and she's specialized in clinical nutrition and research from Harvard Medical School, and also she has a master in biomedical and systems. She's also part of the nutritional organization and part of the science and technology, and she's also author of different publications in journals and recognition. This matter is really, really important, and I would like to begin with a question that is really important to be able to understand what's going on. The first question would be who evaluates, who assesses the evaluators from the WHO to be able to have a sense of security on what WHO says. In the second place,
there's a discordance between what the WHO says, has concluded regarding LCSs and what the clinical guidelines say all over the world, including for both for nutrition and diabetes. So it is important to define, I believe, the members of the panel, what we need to do with this problem in particular. We do have a gap of sorts, a black hole, if you will, between the WHO and the different scientific communities. Clearly, in the real world, the patients exactly tell us what we need to do clinically speaking. So how do we make it so that the WHO can look into better guided studies that actually serve as the base for the reality, which is that LNCSs actually help in the management of obesity and diabetes, amongst other pathologies. So this is a general question that hopefully any of you will take. I believe that there's no good answer for that. That has to do with the evolution of science and scientific evidence. We cannot say today that the WHO made a mistake, but what we can say, though, is that due to the use of other analytical methods, these recommendations that by nature tend to be weak on the weaker side, and we need to understand that sort of language. That is, conditional recommendations, they used to be called weak recommendations. Why? Because the characteristics of the evidence do not allow for a stronger recommendation, which happens when there's no doubt that this recommendation is actually plausible and the evidence is solid, so that allow us to think that these things won't change even with new forms of methodologies or analysis. So we do have evidence that we can, however, question and think that there might be a mistake. Perhaps what does exist is different perspectives to analyze evidence, which is part of normal science practice anyway, part of the scientific dialogue that we engage into. I believe that there are many aspects that have cropped up in terms of, and I'm sure Alonso is going to show them to us, that is aspects as to when we analyze the LNCSs and separately, because not all of them are made the same. And perhaps there's a few of them that we need to be more cautious with compared to the others. What we see with the meta-analysis is that we put everything into the same bag, and although all of these substances have a sweet taste, their molecular composition, absorption, metabolic interaction, biological interaction, excretion tend to vary from one another. So I apologize if I have left into a tangent here, but my answer is that as we have a more knowledge and evidence and better capabilities to review the evidence, we will be better in parsing things out. I second that in that it is very difficult to have an actual response to this. But what does seem to be certain is that we are uncertain that there's nutritional values that we need to evaluate still. And in the changes of research methodologies at the WHO, the WHO therefore needs to adapt to the new trends that happen everywhere, especially in such a media-driven same like the LNCSs. And it is just not just about the international organizations. The national organizations need to do that. We know that most local agencies tend to adopt these recommendations more than the public ones. So this is why public agencies need to find ways in which they can adapt based on the clinical and scientific information that comes from different bodies instead of just the WHO. However, they need to have advisors too, because the knowledge is still very much not entirely abstracted. So these advisors can provide enough knowledge for public policies and consider everything around. This is, by the way, not a topic that is in vogue right now. This is a topic that needs to be in everybody's head all the time. So it is through evidence, supported evidence, and the mega cohorts, like the doctor pointed out, those things help us in driving or steering these types of information into actual action, into public policy in the use of LNCSs. Well, first off, I want to congratulate all of the speakers. It was a great presentation. You reminded me of my students. And I say this because when I've read articles to my students, sometimes the students tend to read the abstract and that's it. And they immediately form an idea, a conclusive idea of what the paper is going to be. But if they had read the entirety of the paper, perhaps their conclusion might have been different. So you were mentioning who evaluates the evaluators, who evaluates the recommendation first. Well, it is us. We who are the professionals of nutrition, because we read the entire article, we are the individuals that need to provide the actual answer and say, guess what? I might not agree with this because of these reasons. And if you were to look into most of the quote unquote recommendations, there's no actual reason as to why we should not use LNCLs. They just say you should not use. However, the evidence tells us as to why we can actually use the LNCS. And, you know, the word of the day is safety, no? So we need to maybe look into that. And that is at the end of the day what science is all about, what research is about, to provide conclusive responses that are not personal in nature. And I believe that in this particular area where we have the weakness of sorts in terms of research, we need to bolster it. And I'll just give you an example of medicine. Just a few years ago, Darren Halen released an article on glutamine, and the use of glutamine was devilized. But we saw in all of participants of the study, they were all going through a multi-organ failure and they ended up dying. They had a high probability of dying. Was it related to glutamine or something else? Maybe it was not the ideal population of studies. So we see the same thing happening here. We see studies that compare different things. There's no clear dosage. The meta-analysis sometimes compare the dog with the cat with the hen. And at the end of the day, who laid the egg? Was it the dog or the hen? So this is why we need to stop a little bit and rethink things and see what type of evidence we're basing things off of. And with that, we will win the game because the evidence is quite clear, quite cutthroat, and we need to follow the crumbs of the evidence, if you will. I agree with everything that has been said so far, and we need to base ourselves in the fact that the WHO gives guidelines that are very general, and every country needs to adapt them. And then for instance, the American Diabetes Association, I'm sure, will adapt as to what the WHO says. I mean, they do so. Sometimes they tell us that the LNCSs need to be used with caution. Sometimes they say that they can be used freely. So we as professionals in health have the actual tools to decide who we go to, who we guide, and how our patients can use the LNCSs. Our population is a population that lives with diabetes, and they can benefit from the consumption of LNCSs, of these products. That doesn't mean that they have to consume them, but if they were to consume them, they should know that they are safe and that the health professional and the patient that is going to receive the recommendation have that certainty that they can actually consume them, that there's an ADI that tells us that it is safe. And with the previous talks that we saw, it has to do mostly with education. Yes, we need to base ourselves in all of these articles and the evidence, but we need to alight things and include everything into our social determinants, because sometimes the articles say about a specific quantity, but they don't tell us if maybe the patient actually sleeps or if they're going through stress or if they exercise. So I believe that the answer should be the fact that we need to assess our patients individually and share with our population the assessment itself with that patient that is suffering from diabetes, that they can actually use safely LNCSS so that they can actually share that with their environment too.
Thank you, Don. I think
Gracias,
a couple of
doctora.
points to make.
Yo tengo algunos puntos que quisiera establecer con ustedes. Uno de ellos es que
WHO is
la OMS no tiene los
it's not magic.
suficientes fondos, no es
These are
magia.
scientists, I think,
Son
trying their
científicos
best.
que
There may
están
be some
tratando de hacerlo
biases, I
mejor.
think that's
Quizá algo,
part of it. So part of it, I think, is supporting the process, like who is on the new guy committee. And I know Kieran Ford, a colleague of Keys to Graph, is launching a petition as it relates to the UPF committee. I think we have to make sure that we have the right composition of committee. And I'm not talking just about biases, but also expertise. I think in this particular case, I was trained by Jörg Meerpol, who's on the new guy committee, as the grade expert. He's an excellent grade expert, but he's not a nutrition expert. And you need people that have nutrition methodology, because there's a lot of methodological issues related to nutrition. So I think ensuring that we have the right composition of committee and the right experts, like there's some really strong experts, but ensuring that, I think, would help. The other thing too is I think we can be hopeful. I mean, they did make the change for saturated fat. It just took 8 years. So I'm hoping with consensus around best methods, which would be the other thing, is generating that consensus, that we would see the same change here. And in any, for that matter, any recommendation that might come out where they would employ and use the best methods. So I think the best methods are important, and it takes time sometimes for these organizations to catch up. But I think we need to support the WHO in having better committees, better composition, more transparency around the composition and input, public input on the composition. And I think also ensure that the best methods are being applied. And I have one other comment around Hugo's, which I thought was important, is the epidemiology is not looking at individual sweeteners, and that's part of the issue. And these are very heterogeneous in terms of how they're absorbed, distributed, metabolism, excreted. But what we can know from the epidemiology, which is interesting as it relates to aspartame, the one thing it probably is a proxy for is aspartame. And when we see those benefits, because most of the FFQs, when they were collected of beverages, the main sweetener, like 95% in Canada, North America, and I think looking around Latin America, is going to be aspartame and ACE-K. So I think it really is a good proxy probably for aspartame and ACE-K, but we don't really know, and we need to study some of these other sweeteners. I think we still are obliged to recommend that we need more research.
Doctor Cavagnari, por favor.
Muchas gracias. Bueno, coincido con prácticamente
Agree
todo lo que se ha
with
dicho.
practically everything that has been said so far. What I wanted to point out, and I'm sure you commented that in your talk, John, is when you made the difference between those recommendations that are mostly based on public health and those that are clinical practices that are based mostly in clinical assays, that is the clinical practice itself. The initial question was, what can we do as professionals when we have our patients in the office? Because one thing is the research itself, and the other thing is the office, the doctor's office. And when we have a patient with us, we know, because we see on a daily basis, that things might work. And they go hand in hand with what John pointed out, the comparisons themselves. This is why I believe, or I am optimistic in that we will have a convergence into the future as we had with trans fats. Where I'm going with this is, let's say we have a patient with us that drinks 2 liters of water a day. Nobody is going to tell that patient to no longer drink water and substitute that for LNCSS. That makes no sense, because we're changing with the gold standard for something that is subpar. But if, say, you have a patient that drinks 2 liters of sugary beverages a day, and we tell them, guess what? You need to maybe perhaps drink something with LNCS. we are replacing those calories and sugars with something that is non-caloric in nature. And it actually works. We have definitely seen that it actually works. So this is something that we see in practice. And this is why comparisons are so important. We need to compare, therefore, what happens when we remove something that is high calories like sugar, and we add something that is non-caloric like LNCSs. So we need to base ourselves mostly as to what the clinical practices say, because this is what we see on a daily basis in our doctor's offices. And we know that the substitution of sugars that we know give a 4 kilocalories per gram, and we substitute that from LNCSs, it replaces all sort of free sugars and other deleterious effects. Hopefully that will be the way that we will follow, and hopefully that won't take us 8 years so we can converge together like we saw in the case of trans fats, where it was a problem for everybody. Okay, now we're going to go for questions from the audience. Hello there, Brian. Thank you for the panel. I do have a bit of a question. Looking into the Latin American context, in which obesity rates are very high and sugary beverage consumption is also very high, I'm sure there are many countries out there that are never going to create a guideline by themselves. I mean, hopefully they have a guideline by the WHO. So the necessity of creating a Latin American consensus that stems directly from Latin America by knowing the reality in order to orient those countries and authorities and health professionals in healthy populations to adapt their guidelines. Also for patients that are suffering from a certain pathology. I can definitely tell you that I've witnessed in several gatherings, for instance, in the Ministry of Health of my own country, and they tell us that they do not care about scientific evidence to make a decision. And which is really terrible, honestly, because you can go into the meta-analysis and you can do give the evidence. The authorities tell you, well, this is a waste of time. I might as well do something else. So do you believe, however, an important tool, having a regional consensus would be an important tool for all countries? Do you think that would be the case? I don't know if anybody wants to take that. I'm going to answer that. What I try to do is to call upon experts within the region, and I showed that consensus can be a powerful tool. I know that many of us have participated in them since 2016 or 18 that are no longer updated. So this is why it is important to consider an updated tool of consensus, because we need to show new evidence, regardless of whether it was published in recommendations for LNCSs by the WHO or not. Everything that John pointed out is great. We need to put that in the hands of everybody that needs to know about this, and maybe put that into knowledge that would be more easily parsed out by the general population and create consensus within Latin America. And I'm sure that there might be 8 or 9 countries in Latin America that have hard facts and data. We can definitely contextualize these pieces of information and locate them with the necessities and create a consensus that would therefore be a tool that is very powerful in order to create public policies. I definitely want to agree with that. I am sure there's a lot of countries that have a lot of data, not only in obesity, but a few in Latin America even have information about physical activity. Not that many countries, sadly, but at least maybe 4 of them have information on physical activity, and it's something that we can tackle. And in order to create public policies, however, we need something more than studies created in other countries. For instance, you sometimes go to the politicians and they're going to ask for information in your own country, which is something that we don't do in Latin America that much. And that unfortunately stops the conversation with many policymakers, because they tell you, well, these studies happen in the United States, or maybe they happen in China, or what have you. But how can you translate that into real benefits, economic benefits for the population? So definitely consensus is the first step. When we have scientific communities gathering and taking a position, that provides you with a tool so that you can approach the politician and tell them, well, this is a Latin American consensus, so this is a very good first step. It has worked with certain things that we have done in Latin America, and I can definitely give you the clear example that it is not easy, but it is a very first good step that needs to be taken, and we can maybe build from that. We need to gather together as a community and create a consensus because we have the evidence. It is there for the taking. We just need to create a real narrative that is scientific mostly. There's one last question because we're unfortunately running out of time. Okay, no questions. So I want to echo what the doctor said. Dr. John Sievenpiper said, sorry for butchering your name. The pyramid of studies, of research, and the clinical studies are the more specific and more sensitive, and those are the ones that we need to aim for these types of work. And on the other hand, the Diabetes Association that I chair is always open to provide any type of multi-country study you might need in order to reach a consensus. Especially in Latin America, policies tend to be so weak that we actually need a very powerful reinforcement coming from or stemming from scientific communities. Once again, I want to thank you all and a big hand to our speakers. Thank you. Thank you for that.